To this podcast on airway management during CPR. My name is Jerry Nolan and I am a consultant in anaesthesia and intensive care medicine at the Royal United Hospital in Bath. I'm also one of the co-investigators for Airways 2, and this presentation was initially made at a research meeting that was held in Birmingham on the 12th of October 2015. What I'm going to try and cover in the next half hour or so is a little bit of an update on the Resuscitation Guidelines 2015, published in October. I'm going to talk a little bit about the all-core treatment recommendations, specifically those relating to airway management during CPR, and then we'll provide an update on some recent pre-hospital airway management in CPR research, and then talk finally about some aspects of capnography in CPR. For many years now, the scientific reviews on resuscitation have been undertaken and coordinated by the International Liaison Committee on Resuscitation, which, as you can see, now has fairly global representation. These guideline reviews or resuscitation science reviews tend to take place every 5 years or so, with the most recent being at the beginning of 2015, with the output from that published on the 15th of October this year. For the first time in 2015, the systematic reviews have been undertaken using what many would be regarded as the gold standard in evidence-based medicine, and that is the grade system, or grading of recommendations, assessment, development and evaluation. This is a fairly comprehensive system that allows us to evaluate the quality of resuscitation science. The output from that scientific review was published in the journals Resuscitation and Circulation in October, and both of those are freely downloadable from the relevant journal websites. A particularly useful resource exists at the end of the executive summary, which appears in both of those journals, and this slide here just shows the relevant questions related to airway management that appear in the table at the end of the executive summary, and there are some 260 scientific reviews, and by clicking on the hypertext link with the code such as ALS 714, it will take you to all the resources that we used for that scientific review. So that would be all the relevant papers, the relevant slides that were presented, etc. So it's a valuable resource. From the scientific review, treatment recommendations where possible were generated, and this is obviously one that's relevant to the topic in question. So we suggest using either a supraglottic airway or tracheal tube as the initial advanced airway management during CPR. And you will see there that it's a weak recommendation that's based on very low quality evidence. And this is part of the grade terminology that evaluates the quality of the science that we have behind that. And the reason it's a weak recommendation and it has very low quality of evidence is, as we'll see, most of these studies are entirely observational. There are no randomized controlled trials published as yet. There were always quite a few caveats to these treatment recommendations, and these were put under the heading of values and preferences. So here we can see the type of airway used may depend on skills and training of the healthcare provider. That may seem obvious to most of us, but of course it does confound the studies that are undertaken in this particular field. We recognise, of course, that tracheal intubation requires considerably more training and practice. There are also well-recognised complications associated with tracheal intubation, such as esophageal intubation and increased hands-off time in comparison with the supraglottic airways. And we also recognise, of course, that airway management is actually really quite complicated to study, because both supraglottic airway and tracheal tube are frequently used in the same patients as part of a stepwise approach to airway management. And it's actually very, very difficult to formally assess that. After every treatment recommendation, there was always a listing of knowledge gaps, and in this case, no RCTs of initial airway management during cardiac arrest. Of course, we all know that that's no longer the case because we have some studies ongoing, which we'll discuss in a moment. The type and duration of training required for each device is unknown, and it's very difficult technically to study a stepwise approach to airway management. Although ILCOR sets or reviews the science and establishes treatment recommendations, the specific guidelines, which are much more aligned to the kind of practical way that we deliver CPR, are devolved to regions such as Europe, the United States, or even to individual countries, such of course in our case the United Kingdom. And those production of those guidelines and the implementation thereof will be down to, as far as Europe's concerned, the European Resuscitation Council, and then as far as we're concerned in this country, the Resuscitation Council UK. The European guidelines are published in resuscitation, and those are all available across the whole domain of resuscitation, available for free download. And likewise, in the United States, the American Heart Association have also published at least an update to their 2010 guidelines. They have not this time published full comprehensive guidelines. This is the paper for the executive summary for the ERC guidelines, and if one wanted a reasonably concise overview of all the relevant guidelines with most of the relevant references, this is probably the single best paper to look up. As far as the Resuscitation Council UK is concerned, it produced new guidelines this year, and this whole guideline process for the RCUK has been quite NICE accredited, which reflects the standard to which we work when producing these guidelines. The Resuscitation Council guidelines are available online, and the website will come up. Website address will be on one of the next slides, and we can see we really cover the full range of resuscitation subjects within these guidelines as listed on the slide. That's the RCUK website, and if you go to that website and click on guidelines, it should take you to this screen, which gives you rapid access using a series of hyperlinks to the relevant sections of interest. And of course, as far as the pre-hospital audience are concerned, then the section on pre-hospital resuscitation is perhaps the most relevant. And you can see there are also 11 sections altogether there, and it's possible either to just read through those sequentially or just click on the topic that interests you most. As far as airway pre-hospital airway resuscitation research, there are some studies ongoing, apart of course from the Airways 2, which is what we're perhaps most interested in. In the United States, the Pragmatic Airway Resuscitation Trial, or PART, has either just about or is about to get underway with recruitment, and this is a study that will look at a primary endpoint of 72-hour survival and will after out-of-hospital cardiac arrest, and will compare initial management with tracheal intubation versus the laryngeal tube. The laryngeal tube happens to be the most common airway, supraglottic airway used in the United States, with some data that I'll show you in a moment. That's why that particular device has been selected. We also have another ongoing randomized controlled trial, this one in Paris. Primary outcome, 28-day, neurologically intact, so that's cerebral performance category 1 or 2, and recruiting at the moment due to finish recruitment in 2017. And this study is comparing initial bag mask ventilation with intubation only after return of spontaneous circulation versus tracheal intubation as soon as possible. And so the results of that study of some 2,000 patients will be of considerable interest to all of us in this field. What we've really got at the moment in terms of pre-hospital airway management during resuscitation, in terms of research, is really largely observational studies, and perhaps one of the best well known is of course the huge all-Japan Utstein registry, where they collect many data items relating to resuscitation. But for airway management particularly, we can see here huge data set, over 600,000 patients, Of course, if you look very closely at those figures, the vast majority are managed with bag mask, although supraglottic airways are also very commonly used. And if one just looks at the raw data of CPC 1 or 2 at 1 month, first of all, those figures are very low compared with ours, but that's because the Japanese, for a variety of reasons, tend to transport virtually all their, and tent resuscitation and virtually all of their out-of-hospital cardiac arrests. And you can see raw data suggests that the outcomes are much better with a bag mask compared with any one of the other 2 advanced airways. But of course there are many confounders in that, and they've attempted to adjust for those confounders or potential biases in that data using statistical analyses. You can see on the last row, and the adjusted odds ratio, so trying to adjust for those confounders, still leaves us with survival rates that appear to be 1/3 of those in the bag mask group when you look at the advanced airways, either of the advanced airways. But the suspicion, of course, is that there are still confounders in there that have not been accounted for in the statistical analyses, and really the only way we can work this out is by prospective randomised trials. In the United States, they've published some data on their airway management. This comes from the Resuscitation Outcomes Consortium. It's data now, it was published 3 years ago, so it's probably getting a little bit dated. But we can see here that as far as which device is used, it's again overwhelmingly the tracheal tube in the US system. And then if you look at the use of the supraglottic airway, almost 2,000 patients there, but the 2/3 of those are laryngeal tubes. When they analyse their data and try to adjust for confounders, if we look at survival to hospital discharge, neurologically intact, we can see it seems to favour tracheal intubation, and this is also true for 24-hour survival and return of spontaneous circulation. But I must emphasise again that this is observational data, and there may well be confounders in there which are influencing those results. There's been a much more recent meta-analysis of tracheal intubation versus supraglottic airways and out-of-hospital arrests, and I think this is a useful paper to look at just because it really lists all the various observational data that we've got. And the only reason to show this slide, which is quite complex in terms of the size of this table, but if you look at just that last column where we have quality of evidence for each of those studies, you can see, and this is using the grade-based system, you can see that the majority of those are very low quality of evidence, and the best is still low quality, and that's because they're observational studies with risk of bias. If we look at survival to hospital discharge as the endpoint, looking at those studies, we can see that if we look at all the studies, then there's basically no statistical difference between supraglottic airways and tracheal tube, although it's tending or trending towards favouring tracheal tube. But at the bottom set, which is just the sensitivity analysis, where they've only looked at those studies of low quality, so they've eliminated those of very low quality, again we can see no significant difference, and in fact it's pretty well almost sort of centrally placed at 1, suggesting no difference at all. But if we look at survival to hospital discharge with CPC 1 or 2, particularly if we go straight to the bottom where the sensitivity analysis has been confined to the low quality studies, then we can see it just is favouring tracheal intubation, and significantly so. But again, these are observational studies. One of the potential reasons that has been put forward in the last few years for why supraglottic airways may, in some of these observational studies, end up with worse outcomes than tracheal intubation might be the influence of the cuff that some of these airway devices have in terms of the potential to cause pressure on carotid arteries and therefore reduce carotid artery blood flow. And this really came about from animal studies such as this pig study, where they showed that when you looked at blood flow in the carotids using the combi tube, and comparing it with tracheal tubes, but comparing either the combi tube, the laryngeal tube, which the Americans tend to call the king tube, and the laryngeal mask, we can see reduced carotid flow for those devices, particularly for the combi tube, which has particularly big pharyngeal balloons that are blown up once it's been inserted. There's been that hypothesis about reducing carotid blood flow with supraglottic airways has been slightly refuted by a very simple human study just looking at patients who happen to be undergoing CT scans with supraglottic airways in place. We've got here an illustration from this series of 17 patients. This is one of those patients. Unfortunately, it's not clear whether this device is whether it's a combi tube or a laryngeal tube, but we can see the large black representation around the trachea, which is essentially representing the cuff that's been inflated. But the two arrows on this illustration are pointing to the carotids, which obviously sit much more laterally in a human than they do in an animal, and it's hard to see that particular airway device is actually compromising blood flow in those carotid arteries. So it may be that something that was true in animals may not be true in humans. We have got some other studies out there in terms of looking at supraglottic airways in out-of-hospital cardiac arrest. This was a study from France involving emergency nurses, and this was a pseudo-randomisation trial. In other words, they alternated each month using either the laryngeal tube or just a bag mask device. And what they were recording as their endpoint was the compression fraction, in other words, the percentage of time that compressions are ongoing. And we can see from this relatively simple study that the laryngeal tube was associated with a compression fraction of 75%, which was significantly more than the 59% associated with the bag valve mask. They had a fairly high failure rate for laryngeal tube insertion of 23%, which is a figure that some other studies have reproduced as well. So it may be the laryngeal tube is not the simplest of the supraglottic airways to position. Another study that's been recently published involves, again, use of the laryngeal tube by emergency medical technicians in out-of-hospital cardiac arrest, this time in Austria. Interestingly, their pre-hospital system consists largely of volunteer basic EMTs, which is obviously an unusual setup. They had training in mannequins only, which is clearly a limitation, and they had a maximum of 2 attempts of the laryngeal tube. And if we look at the success rates for ventilation, and we can see the bar chart on the right side of that slide, the first group, the red bar, is the bag valve mask group, where for whatever reason the laryngeal tube was not available, and clearly that's not a randomised process, that's just there were obviously reasons why it wasn't available, and their success rate with bag valve mask was really relatively poor in terms of ventilation, just over 20%, which is very low indeed. The laryngeal tube group is not bad, some 93% successful ventilation, but that's where they actually had the laryngeal tube and left it in. But there was another group where they failed to insert the laryngeal tube and then went back to using a bag mask, and they had very low ventilation success rates of just 15%. So an observational study probably of limited relevance to the pre-hospital system in the UK for a whole variety of reasons, not least of course because of their relative lack of training. One of the final topics that wanted to discuss in this podcast was use of waveform capnography, which has got a much higher profile in the guidelines 2015. To the extent that really there is a strong view that tracheal intubation should not be used in the absence of waveform capnography, and this I think is a much stronger recommendation that has been made in the past. There are a whole number of reasons for the use of waveform capnography during resuscitation. The first, of course, is that by using it in conjunction with a tracheal intubation, we can show that the tube is actually in an airway and not in the esophagus, because you really should be seeing at least some end-tidal CO2 during chest compressions. If you can't see CO2, the tube is not in the airway and needs to be taken out. The second thing that we can do is to use it potentially for evaluating to some extent the quality of CPR. So the higher the quality of CPR, the higher the end-tidal CO2 values, and that's shown in the sort of middle portion of the top waveform on that slide. And then finally, it can be perhaps a very useful and early indication of successful return of spontaneous circulation, when there should be a relatively sudden increase in end tidal CO2. So I think that's something which we'll be seeing a lot more of. Some interesting data in relation to CO2 and compression depth, and this is observational data coming from a study where they've actually got all the relevant data. So they've got devices that are recording compression depth as well as having end tidal CO2 in place, and we can see here. It's a complex slide because the different colour lines reflect different compression rates, and we'll see those on the next slide. But we can see across here that if we look at the compression depths ranging from that on the x-axis from 30 millimeters up to 60 millimeters, we can see a real linear increase in end tidal CO2 as those compression depths go up, which I think is a very nice illustration of the relationship between compression depth and essentially cardiac output, which is what end tidal CO2 is showing you in that particular case. So strong relationship there. Interestingly, when we change that x-axis to compression rates, and on this occasion the different colour lines are reflecting different compression depth, so it's almost the inverse of the previous slide. Interestingly, we don't see that relationship, so it doesn't appear, at least in that range of compression rates between 90 and 130, that compression rates are associated with end tidal CO2. So one might conclude from this, I think, very interesting study is that compression depth perhaps outweighs rate in terms of performance for quality of CPR in terms of forward blood flow. So to summarise all of that, the first and most important is that new resuscitation guidelines were published on the 15th of October. Those are all free and available for download either at the Resuscitation Council UK website, or if you prefer to look at the European guidelines, they are downloadable from the ERC website or from the Resuscitation Journal site. At the same time, published on the same day, was the 2015 ILCOR Consensus on CPR Science, and this is really the source to go to if you want much more detail around the science behind those guidelines. As far as airway management is concerned, we've got 3 major RCTs on pre-hospital airway ongoing at the moment. We've got that one in France, looking at tracheal tube versus delaying until after, looking at immediate intubation versus delaying until after ROSC. We have the American study, which is looking at the laryngeal tube versus tracheal intubation as the initial airway management choice. And of course, most importantly, we have Airways 2, which is really looking at the I-gel versus tracheal intubation for initial airway management during CPR. I've shown finally some of the evidence for capnography during CPR, and I think that's very much an evolving field. Thank you for your attention.